Good afternoon. So we will be presenting, we are from Subgroup 2. We will be presenting on Primary Healthcare 1. So my name is Tivashni. I'll be starting off the presentation. So I'll be presenting on level of care and level of prevention. What is level of care? So level of care basically is the amount of work necessary to identify, address, protect or maintain a person's physical or emotional condition. It's divided into three types of care: primary care, secondary care, tertiary care. As in for primary care, it's health clinic and polyclinic. For secondary care, it's district hospital. For tertiary care, it's referral or regional hospitals. Primary care is also known as essential treatment. Secondary care is also known as specialist treatment, and the tertiary care is known as hospitalization treatment. So what they provide in this care, like for primary care, the services provided are basic assistance, coordinating treatment with various levels of care, especially for secondary care, treating particular body systems, ailments, and also conditions. For tertiary care, necessitates highly specialized with tools and knowledge and intricate processes and therapy. So next would be level of prevention. So level of prevention is enhancing the general health of population, communal recovery and treatment. So it's divided into three: primary prevention, secondary prevention, tertiary prevention. So for primary prevention, it's underlying condition leading to causation. For primary prevention, it's specific causal factors or at risk. And secondary prevention is early stage of disease or asymptomatic disease. For tertiary prevention, it's late stage of disease or established diseases. Examples of primary preventions are public health, primary health care, and other factors. For secondary prevention, it's public health, primary health care. And tertiary prevention is specialist hospitals, services, and hospital care. What are the services provided in primary prevention? It's control of vectors, which is known as prevention of transmission by transfusion, by organ transplantation, and accidental transmission. For secondary prevention, it's case detection, early intervention, anti-parasitic eradication, and routine physicals. For tertiary prevention, it's managing side effects, maintaining care, and using both pharmaceutical and non-pharmacological methods.
Hi, my name is Srinitya Nair. So I'll be presenting on the primary healthcare. Next. So for the definition, it is the essential healthcare made universally accessible to individuals and acceptable to them through full participation and at a cost the community and country can afford. So what does it mean? Means like we have few key points. First would be the essential. So essential is like the primary healthcare consists of only the bare essential of our healthcare needs, which means like the bare minimum which needs to be given in any medical condition. Next would be accessible, which means it should be located at a place where everyone can access easily. Third will be the acceptable, it's acceptable to them. So it should be acceptable to everyone. For an example, like if rectal examination or colonoscopy might not be accepted by the majority, so it's not considered as the primary health care. And then followed by the full participation. So the whole community should involve to carry out this primary health care. So what are the principles of, and also, sorry, finally, it's about the cost. So it should be affordable for both community and also the country. So the principles of primary healthcare, first would be the community participant. As what I mentioned earlier, without a full participant of a local population, discharging the healthcare needs is not possible. Next would be appropriate technology. So to carry out our primary healthcare services successfully, you should have appropriate technologies. Third will be equitable distribution. So majority of the healthcare services concentrated at the town places. So primary healthcare aims to balance it by focusing on the rural area as well. So finally, it's the intra and intersectoral coordination, where the PHC, which is known as the primary healthcare, cannot be provided by healthcare sector alone. So other department of the government must also work together. Next. So there are a few elements of primary healthcare. So the acronym will be elements. First, education. Next will be the local endemic diseases, expanded program for immunization, maternal and child health care, essential drugs, food supply and proper nutrition, treatment for communicable diseases, non-communicable diseases, and also injuries. And finally is the safe water and sanitization. So next will be the primary care. As for the definition, it is like a day-to-day healthcare given by the healthcare providers, and it's like the first point at the first where a patient and a healthcare system contact. So it provides individual with access to the information and resources they need for optimal health outcomes. So there are few levels. We have primary. So primary is like when you visit the clinic when you have certain sign or symptoms. Sometimes you also can go for screenings or checkup. Next will be the secondary level, where your primary care providers will refer you to the specialist center. And the third one would be tertiary care. If you are hospitalized and require a higher level of specialty care, your doctor may refer you to the tertiary care where it requires highly specialized equipment and expertise. For an example, like for coronary artery bypass, they will refer you to the hospital for um, specific treatment. Yeah. So what are the differences between the primary healthcare and also primary care? So first, primary healthcare is actually at a community level, whereas the primary care is at individual level. Primary healthcare, it involves multi-sector teams, for an example, like general practitioner, occupational services, physiotherapists, or social workers. Whereas for primary care, it involves the healthcare professionals like physicians, nurses, and also pediatrics and etc.
Okay, next I will move on to the Quality Assurance Program, or as known as QAP, in the healthcare system, developed by KKM, Kementerian Kesihatan Malaysia. So it is actually like a guideline for or indicators that set by the KKM, which is divided into three approach, which is in the national level approach, DSA, which is the district approach, and also the HSA, which is the hospital approach. So to move on, what is the difference between of these three approach? So the first one is the national indicator approach. So the major difference here is the top down and the bottom up words, which is the top down is actually the basically it is from the general to the specific level, and it is to identify the big picture and all its component from head to toe, what I can mean. Why it's called a national, because it covers the area of the nationality, the national, I mean, which is the whole Malaysia. And also there is the district and also the hospital indicator, which is the bottom up approach, which is it is from down to the up. It is from specific to the general approach, which is they follow the guideline, but it's all from their level itself. And the indicators are then developed for these areas, and the data collected for each indicators are subsequently analyzed. What is mean here is when for the national indicator approach, which is the first line of the approach, the data is collected, and the standard indicators were developed, and the reasons for the shortfall in the quality was analyzed, and the action was taken in the national level. While in the district level, it is local people or the people in the district solving their own local problems. They will set their own standards, and the actions was taken to their own district level, and as well as the hospital approach, which is they find out the problems and they solve by their own by make their own standards, and the action was taken to their own hospital. So for example, the national indicator approach, the first one is for the STEMI, or ST elevation myocardial infarction, which is the optimal or the standard target for this ST elevation myocardial infarction mortality rate or fatality rate is below 15%. So it is the indicators that the national level set to all the district and also the hospital, and that we must we must target to achieve that goal. And then for the district example is the most common dengue hotspots and the prevalence of food poisoning. And the last one is for the hospital indicated approach, or HSA, is they set the waiting time in the emergency department in their own hospital is below 24 hours. So they must achieve these goals or this target. Next, I will talk about the achievable benefit not achieved, or for the short form is ABNA. As you can see in the diagram below, it is the difference between the optimum achievable result, which is our target or our indicators set by the national or the district or the hospital levels, and different between that with the results of being actually achieved by us. So the difference of that is our achievable benefit not achieved. So the target is we need to reduce this ABNA to arrive or to achieve the optimum target. There is example which is the three component, which is the sins of omission, sins of commission, and the other last one is the sins of effectiveness. So I will give the example for sins of effectiveness, which is the abuse or waste of expensive material in hospital, such as beds, or the drugs, expensive drugs, or unused the uninvestigated procedures. So it will actually can lead to the value of the achievable benefit not achieved. So that's one of the example why for IBNA is increasing.
Lastly, for Health Clinic Advisory Panel, is actually introduced by the Malaysian Ministry of Health in 1994, which it acts as a vital bridge between government and also the community. The objectives are, firstly, for distribution of accurate information related to local health problems. Secondly, effective two-way communication between community members and also staff of the Department of Health. It's for appropriate health activity implementation, in which the opinions and views from the community members will be considered, so that the health activity implemented is appropriate to the local and also the culture of the community. It is to assess effectiveness of the activities implemented, in which after activities being implemented, then they will receive the feedback from the community to assess the effectivity, to create mutual responsibility attitude between the community and the Department of Health in dealing with health problems, in which not just one side, only the community or only the Department of Health is concerned about the health problems. So we wanted to create the mutual responsibility attitude. And lastly, the transparency between Department of Health and community, in which this approach can enhance the image of the health clinic in the eye of the community. For hospital visitor board, the board of visitor is made up of volunteers who are appointed by the health ministry for a 3-year term. Their roles are, firstly, to connect the hospital with community, in which the hospital visitor board is responsible in giving clear explanation about facilities and also services provided by the hospital to patients and families. And next, they are to conduct hospital visits, in which they will observe how the services and also facilities provided by the hospital towards the patient and also family. And at the end of every hospital visit, they will write a conclusive report and also discuss this matter in a meeting with the hospital visitor board. They also provide welfare services for patients and family. For example, they provide books or any reading items for patients and family, and also like in case of unfortunate patients, they will like provide clothes. And lastly, engage in hospital activities, in which the hospital visitor board is to be involved in hospital activities with the community, such as blood donor campaign. And for the health clinic advisory panel and hospital visitor board differences, for HCAP, the individual is appointed can be from political background, whereas in hospital visitor board, it cannot be from political background. Whereas the hospital visitor board is between the community and also hospital. And lastly, the HCAP is appointed by the officer in charge of health clinic, and the hospital visitor board is appointed by the Minister of Health itself. That's all from us. Thank you.